prostate abnormalities affect many men as they age. And one of the common misconceptions typically involves that some of the symptoms that men have because of an enlarged prostate, which we refer to as benign prostatic hyperplasia or BPH, can be mistaken for symptoms because they have prostate cancer. The two are definitely separate, but can coexist as well. And we at PCI Urology offer many forms of therapy for men with BPH, which includes medical management, obvious state-of-the-art diagnostic evaluation, including non-invasive bladder testing, et cetera. And some of the office-based procedures, such as a urolift, are things that we do for men with obstructive voiding symptoms. As I said, the two can coexist, and typically for men, prostate cancer tends to be the most common cancer in men, second leading cause of cancer death. But the most important thing is it's very common, and many men diagnosed with prostate cancer will simply live with it and not need to necessarily be treated. And so that distinction needs to be very clear. Screening for prostate cancer is recommended for all men starting at the age of 50, and a rectal examination and a yearly PSA test is important. A PSA stands for a prostate-specific antigen. That's a blood test that can be simply performed and then interpreted by your primary care physician and by a urologist if need be. And if there are abnormalities in one or both, that will then lead to additional testing and diagnostic evaluation. That also has changed dramatically over the years. There are new, more specific blood tests that can be performed. We're now doing a lot of 3 Tesla magnet MRIs for the prostate that can characterize lesions in the prostate that are at higher risk for potentially having prostate cancer cells present, which may lead us to do a targeted biopsy called a fusion biopsy or a transrectal ultrasound guided biopsy in the office. So there is a clear distinction between those two. Most of the time, prostate cancer occurs without any symptoms until it's potentially advanced beyond the point where maybe cure is an option. So that distinction needs to be made. Prostate cancer is diagnosed typically with a transrectal ultrasound-guided prostate biopsy that is an office-based procedure that takes approximately 15 to 20 minutes to perform. In some of the newer technologies now, we occasionally will do what's called a fusion biopsy, where an MRI of the prostate will be done, and then we will superimpose MRI images on ultrasound images so that we can do a targeted biopsy if there's a specific area in the prostate that appears to be abnormal. But in general, the diagnosis is made after a patient is found to have either an abnormal PSA, an abnormal rectal examination, or potentially both of those. And typically the majority of people have a biopsy done in the office and minimal risk of infection or bleeding, and they go home afterwards with a limited amount of recovery from that. Once the diagnosis of prostate cancer is made, it's important for patients to understand that not all prostate cancers are alike. And there's a specific grading system where the cells are given a grade under the microscope. And certain grades of prostate cancer are felt to be much more indolent, much more slow growing, and potentially something that we can manage with what we call active surveillance, which is simply monitoring the PSA, monitoring the rectal exam, repeating biopsies at a specified interval, and potentially following that with MRI. With that being said, there are certainly patients who are diagnosed with prostate cancer at younger ages that have more aggressive forms of prostate cancer where they clearly need to be treated. And that becomes complicated simply because it's not as simple as this is the problem, prostate cancer, this is the treatment. There are multiple treatment options that are available, and we pride ourselves on adhering to what we refer to the National Comprehensive Cancer Network guidelines, or the NCCN guidelines, evidence-based guidelines that help us to guide the patient. And we also pride ourselves on something that the American Urologic Association really stresses, and that's called shared decision-making. And shared decision-making comes into play when we talk about doing a biopsy. Shared decision-making comes into play more prominently when we start to talk about the treatment options for prostate cancer. And as I stated, there are some patients who are perfect candidates for what we call watchful waiting, which is simply not really doing anything because of their age, other medical conditions, or the grade of their prostate cancer. There is active surveillance, as I referred to, but there's also treatments that are done with the intent to cure the patient of their prostate cancer. And traditionally, those involve surgical removal of the prostate, treatment of the prostate with some form of radiation therapy, whether it be external beam radiation therapy, implantation of radioactive iodine seeds, or a combination of those. And there's also cryoablation of the prostate, which is freezing the prostate. The last two options are more minimally invasive, and some are appealing to some patients because of some of the side effects that may be avoided with those treatments.